HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I will be speaking to Dr. Alexander Sweetman on behavioural treatments for insomnia. Dr. Sweetman, tell us about yourself.
Yeah, so thanks, David, for having me on the podcast today. I'm a program manager with the Australasian Sleep Association, which is the peak scientific and sleep advocacy body in Australia and New Zealand. I manage a 3-year Commonwealth grant trying to improve the management of sleep disorders, mainly trying to provide education and implement different interventions throughout the primary care system, so working with GPs, psychologists and practice nurses. And I also have academic status at Flinders University, so I work on quite a few clinical research trials, especially around insomnia and the comorbidity of insomnia and sleep apnea at Flinders University there.
Alexander, it certainly sounds like a lot is happening in this space with regard to research and providing access and services to people with insomnia. So a simple question, why is it so important to talk about insomnia?
Yeah, we think that insomnia is one of the most prevalent conditions that present to general practice. The Health of the Nation survey coordinated by the RACGP, I think for the last 6 consecutive years, has reported that sleep problems are among the 3 most common complaints or symptoms that patients present to general practice with. So we know that sleep is really important and that it's really common in general practice. Insomnia is the most common sleep disorder. Why is it important? Well, we know that insomnia reduces daytime function, mental health, productivity, and quality of life. So there's some pretty substantial consequences of insomnia. However, it's not all sour and bad news. The good news is that we have a really effective treatment for insomnia. And like you say, there's been a lot of work in this space among educators, implementation scientists, and researchers to bring this treatment to the forefront and make it more readily available in Australia.
That's really important you contextualize it for us, but I would like to see a process in action. So, Alexander, just to help my GP listeners, we're going to present a case to you. So let's just imagine a 54-year-old woman coming in and seeing a GP saying, Dr. Jack, I can't sleep. So my first question is, how would Dr. Jack actually know that insomnia is the issue and not something else?
Yeah, good question. So some patients might present with a more general complaint or symptoms of poor quality sleep or non-restorative sleep, and others might present talking about feelings of sleepiness or daytime impairments that might be indicative of an underlying sleep condition or sleep problem. So I guess part of the first step, if a patient presents with this more general complaint, might be to start to ask different questions about different types of sleep disorders to narrow down on what might be happening. So regarding insomnia, insomnia is characterized or defined by self-reported symptoms. So it can be assessed quite easily in the general practice setting. We're mainly looking at difficulties falling asleep at the start of the night, difficulties waking up or long awakenings throughout the night, or early morning awakenings with difficulties returning to sleep again. So basically sleeping difficulties at the start of the night, middle of the night, or early morning, late in the night. And for a diagnosis of insomnia, this should be accompanied by some daytime impairment as well. And that can include a whole range of different types of impairments, fatigue, irritability, poor mood, sleepiness, almost you name it, it's probably covered in the insomnia criteria. And then the next step would obviously be assessing for other comorbid sleep disorders or other potential sleep disorders that might contribute to the insomnia as well. So other common sleep disorders like sleep apnea and restless leg syndrome, and then less common sleep disorders as well. For a bit of guidance on the assessment of insomnia, there's now a new online GP guideline specifically about insomnia and sleep apnea. And David, I think you've covered this in a previous podcast with Professor Nick Zwar and Associate Professor Ching-Li Chaikutsa as well. And on this online guideline, there's a few standardized questionnaires that can be used specifically to assess for insomnia.
Thank you for reminding me of that interview, Alexander. Some of the listeners may not be aware of it, so we'll make sure we link that podcast to your podcasts. But also, we could get the link to those websites from you as well, so we can link it to.
Absolutely.
Okay, so let's just say that we are able to narrow it down and say, look, this patient indeed has a true insomnia, and the patient has problems with initiating sleep, and occasionally wakes up at 2 o'clock in the morning wondering why they're awake and think they take a long time going back to sleep, and it's distressing them. What do I do next?
Yeah, so assuming that they don't have any comorbid sleep condition that requires concurrent referral or management, the most effective treatment and the recommended first-line treatment for insomnia is cognitive behavioural therapy for insomnia, or CBT-I for short. So there's lots of different CBTs, CBT for depression, CBT for anxiety. There's also one specific to insomnia with a little I on the end. So what we've been doing over the last 5 years or so is to try and make CBT-I much more readily available to general practitioners throughout primary care and also throughout the Australian community.
No, I just wanted to make a question about how very often as a GP, we tend to leap to sleep hygiene thinking that would be the first treatment. But you're really saying, actually, it's not. CBT-I is the treatment. Where does sleep hygiene sit?
Yeah, sure. So sleep hygiene includes a suite of more generic instructions about making the bedroom or bed environment as comfortable as possible in terms of temperature, bedding and sheeting, and light and dark that comes into the bedroom. Limit technology use in bed, avoid caffeine after a certain time in the afternoon, and so on. So this is all really helpful sleep health advice, but we think that by the time a patient is presenting to general practice or other specialist settings, most patients have done this sort of research themselves online and have been able to find a whole plethora of sleep hygiene advice, which by definition, if they're presenting to general practice, probably hasn't worked or hasn't completely resolved the sleep complaint for that patient. So sleep hygiene is helpful, but it should be provided alongside specific behavioural treatments for insomnia. These CBT-I treatment components actually target the underlying causes of the insomnia, and that's how they're really so effective and able to lead to long-term improvements in sleep, mental health, and how people feel and function during the day.
Alexander, not everyone knows what CBI actually is targeting and what are the core or key issues it's working at. Can you tell us?
Yeah, sure. So CBT-I is a multi-component therapy. It includes several behavioural components. We can also provide these as text or provide links to these to accompany some text with the podcast as well. But the main behavioural components are stimulus control therapy and bedtime restriction therapy. Often relaxation therapies are included as well. CBT-I normally includes a psychoeducational component where patients are presented with factual information about sleep, what happens and how our sleep changes throughout the night, and also some of the factors that control the timing and quality of our sleep. This sort of information can be really helpful in justifying the different behavioural therapies that are introduced at the start of CBT-I and then adjusted or titrated throughout the remaining sessions. And then CBT-I commonly includes some cognitive therapy components that aim to identify specific maladaptive beliefs or different beliefs that lead to behaviours that can disrupt sleep rather than have a beneficial effect. So a multi-component therapy. And yeah, again, that's a lot to take in, so we can provide it in text, and it's also available on the new GP guideline.
From what I'm hearing, Alexander, it sounds as if what you're teaching the patient is just how to understand sleep, not to get, if you like, wrong beliefs or derive anxiety from thoughts you might have about it, giving facts and then dealing with your responses to the anxiety. Is that what you're aiming at?
Yeah, decatastrophizing sleep and reducing alertness and arousal is a large part of CBT-I. Probably the main therapeutic element of CBT-I is actually something called bedtime restriction therapy, which aims to temporarily reduce the amount of time that a patient spends in bed. This sounds completely counterintuitive to someone with insomnia, who's more likely to extend their time in bed in the hopes of getting as much sleep as possible. But we know that most of the time, extending time in bed won't actually result in more sleep. Instead, it results in more time spent awake in bed, thinking or worrying or being frustrated in bed about not being able to sleep, and that this can lead to a conditioned relationship between the bed or the bedroom and this state of alertness, frustration, and arousal. So bedtime restriction therapy, one of the most important or most effective therapeutic components of CBT-I, aims to reduce time spent in bed every night for 1 to 2 weeks. During this time, the patient can monitor their sleep on a sleep diary, and then gradually, week by week, the GP or the therapist can assess changes in sleep. And as the patient starts falling asleep quicker and returning to sleep quicker throughout the night, we can gradually extend that time in bed from week to week until a more comfortable equilibrium is found between how long they're spending in bed, how long they're asleep, and how they're feeling and functioning during the day.
It just sounds so simple, and it sounds so counterintuitive, if you said. With regard to sleep diary, could some sort of digital wearable be helpful, or do they have to actually use pen and paper?
Yeah, there's a couple of different modalities of sleep diary that have been developed. So these started as pen and paper. There's a couple of downloadable, so PDF versions of sleep diaries, again, on the online guideline. But there are some digital sleep diaries that can be completed on a smartphone or on a computer after getting out of bed the next morning. So there's different types of sleep diary. Essentially, they all try and capture a patient's self-reported information about when they got into bed, how long it took to fall asleep, when they were asleep, if they woke up, and for how long, and when they got out of bed. And then it can start to distill some of this information and help the patient and the clinician or the program calculate weekly averages. Like you say, bedtime restriction therapy is not rocket science. It's quite formula-driven, protocol-driven, and we think that it can be adapted and delivered in a whole range of different settings, including in general practice.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
I'm so glad you mentioned the different settings, because immediately I'm thinking, I wonder how many psychologists, A, are trained in it, and B, are not swamped by all other health issues and are happy to take on new patients. GPs can have some time, but they too are swamped. So how do you see this actually come into play when you think that a lot of the resources are already pretty chockers?
Yeah, great question. And this is these are some of the barriers that we've been trying to come to terms with and solve over the last 3 to 4 years. So during this time, we've been coordinating a National Centre for Sleep Health Services research, mainly at Flinders University. And the Sachs Institute have really been instrumental in guiding this implementation and education program. So we've been meeting with a big group of stakeholders representing different clinicians and colleges, also consumer stakeholders, the Department of Health, and different sleep advocacy organisations to bring insomnia to the forefront and try and understand what are the barriers and how do we get around these. So you mentioned psychologists. It's probably not a surprise to you that there aren't too many psychologists that specialise in the management of insomnia. The Australasian Sleep Association's Psychologist Education Committee tried to audit all of the psychologists in the country that specialise in insomnia, and we only found about 60 psychologists that specialise in this condition. Most are part-time researchers, part-time clinicians, so we think there's probably only about 30 full-time equivalent psychologists. Completely inadequate.
Sorry, is that in Australia?
That's correct, in the country, yeah. 30 full-time equivalent psychologists that specialise in sleep disorders, yeah.
I can understand the magnitude of the barriers you are facing as a researcher. So tell us how you're thinking around that issue.
Yeah, so the first thing is recognising that is completely inadequate to manage the estimated 2.5 to 3 million people in the country with chronic insomnia. So we need to train more clinicians, and we need other options for people to access this evidence-based treatment. So one, we're working really closely with the Australian Psychological Society to develop some CBT-I education modules and programs that will be hosted through the Psychological Society. We're hoping to get these online in the next 3 months or so, and we think that these will start to pretty rapidly provide more general psychologists with the tools and training to start delivering CBT-I. So that's one thing. The second, we also think that CBT-I can be delivered in the general practice setting by GPs or practice nurses with an interest in insomnia. So a couple of years ago, we published an article in the Australian Journal of General Practice providing a step-by-step approach for a GP-delivered brief CBT-I intervention in general practice. We're also providing education to GPs in lots of different ways. So we have one workshop coming up at Wonka in late October in Sydney, I think, an insomnia workshop. And Flinders University are developing a GP education program around the delivery of brief CBT-I as well. And finally, we think that CBT-I can also be self-administered by patients through interactive online programs. So digital CBT-I programs have been developed and studied for quite a long time. We've also been studying some different digital CBT-I programs in Australia. And if any GPs that are listening are interested in digital CBT-I and accessing this for their patients, I'm running a clinical trial at the moment providing GPs with a digital CBT-I pathway. So feel free to reach out to me. We can include my email address in the text accompanying this podcast as well.
Alexander, toward the end of this podcast, I would like you to just give us a little bit more detail about what you want, who you want, and what you can do. And I'll give you time to tell us about it, because it does sound like a very important tool for GPs. Now, I want to go back to the online tool for GPs and nurses. Is it available? Has it been done? Is it validated? Is it effective?
So no, it is in development at the moment. Researchers and clinicians at Flinders University are working with staff at the GP Mental Health Standards collaboration, and it's probably going to be in development for several months to come. But in the interim, there's a lot of other resources that GPs and practice nurses can access at the moment that will provide education about the delivery of CBT-I in general practice.
So to be fair and to be honest, because you've got so much work ahead of you, the one that's pretty much up and going is your research, and that's delivering a self-administered CBT-I program to the patients themselves. Am I right?
Yes, so that's one of the interventions that is immediately available. So GPs are able to contact me, get involved in this clinical trial, and start referring patients to this digital CBT-I program. In saying that, we don't think that self-guided digital CBT-I is appropriate for every patient that comes through the door with insomnia. So probably 20 to 25% of patients might be more suitable for referral to one of those specialist psychologists still. So this isn't a solution for every patient, but if we can try and provide CBT-I to most patients in this way, that will free up those expert or specialist clinicians to better manage the patients that do require specialist oversight and care.
Can you tell us, therefore, the criteria, if you like, for a referral to the self-guided, or when I should send my patient to a trained psychologist or a psychologist with the resources you're developing?
So a lot of it is based on the patient preference. Obviously, not all patients want to put themselves through a self-guided program or see insomnia as something that should be managed digitally. So that's probably the first and most important thing, to have a frank conversation with the patient about what the intervention is. Second, we think that GPs can apply a lot of their own clinical discretion here, so we can put together checklists and recommendations, but it should all be taken with a grain of salt. GPs know their patients best and are able to understand what sorts of treatments are most appropriate. Because this is a clinical trial, we've got a few criteria. So we think that specialist referral is probably more suitable for shift workers, especially those with a changing night shift, day shift rhythm, just because that's slightly more difficult for a digital automated program to handle. Also, those with epilepsy. So there's some evidence that sleep restriction or deprivation can exacerbate epilepsy. Therefore, we think that that's better managed by a specialist clinician. Patients who are drivers for work or operate heavy machinery for work, probably more suitable for management by a specialist. And also those reporting really excessive daytime sleepiness, which can be indicative of a comorbid sleep disorder like sleep apnea, probably more appropriate for specialist referral again.
Thank you. That was very clear. What about issues such as cost? And we did mention access because, as you said, the psychologist, well, we still need to refer 20 to 25%. What's a situation like these days for referral for a sleep issue?
Yeah, so one of the main take-homes here is that a couple of years ago, we wrote to the Department of Health to clarify whether insomnia is an eligible condition for a mental health treatment plan alongside depression, anxiety, and so on. And the answer was a resounding yes. So we now have confirmation from the department that yes, insomnia, both presenting by itself and insomnia comorbid with mental health problems, is a suitable condition for a mental health treatment plan. So this allows the GP to claim the item rebate for the referral and also covers part of the cost of the patient accessing the psychologist. Depending on where the patient's referred and which psychologist they see, there's often a gap payment, and we don't quite have a response to that just yet. That's probably based on the number of available psychologists and what delivering this type of care pragmatically costs. Alongside that, though, access issues. We know that now psychologists can deliver CBT-I via telehealth, and the same mental health treatment plan referral items and access items apply. And there's some research evidence that suggests that telehealth CBT-I from a psychologist is similarly effective to face-to-face CBT-I from a psychologist, which is great. So people in rural and regional areas at least have a way of accessing some of these specialist psychologists without that geographical barrier.
That's just such a great piece of news because I was just thinking of the unreached regional and rural areas. So that's exciting.
And then obviously digital CBT-I, I'm providing this treatment free of charge throughout the clinical trial, and the plan is to provide it free or for as little money as possible in perpetuity. And digital CBT-I can be accessed anywhere in the country with an internet connection and an internet compatible device.
Now that we're talking about this program again, Alexander, how many people are you looking for to enter the trial?
Yeah, so the GP clinical trial that I'm running at the moment, there's an upper limit of 500 patients which would be recruited. So far, we've recruited about 30 patients to the trial, so we're still looking for patients and still able to provide access to this program for a long time yet. And my aim is to continue research with this program into the future, so there'll be other clinical trials in the future that replace this one, is my plan.
Can you tell us what are the important inclusion and exclusion criteria?
Yeah, so they would be the same sorts of conditions or factors that we spoke about a second ago that might indicate which patients are suitable for a specialist referral versus digital CBT-I, so shift work, epilepsy, driving for work, and so on. Also, comorbid bipolar disorder or schizophrenia, probably more appropriate for a specialist referral. Again, I can provide a link that will list all of those inclusion criteria quite definitively.
Very good. And is it something that the doctor just enrolls the patient online, or is it something the patient has to enroll himself or herself?
Yeah, so the way that I've set it up, the first point would be the GP completing an online consent form just to make sure that the GP understands what the trial is and what they're referring their patients to. And then I've set up a static referral site, which takes about 2 minutes for a GP to complete, just to enter their patient's name, email address, and their own name, to click submit. And then the patient would receive further instructions about getting involved. So GPs can definitely play an ongoing role in the management of these patients, especially providing some motivational support or guidance throughout. And I think it can be helpful for GPs to complete the program themselves the first time, just to get a bit of an idea and feeling for what sort of information is provided and what sort of treatments and adjustment of treatments are provided week to week as well.
Apart from looking at the ongoing role that you just described, are there particular things we ought not to prescribe for whatever purposes for patients going through either the digital CBT-I or the ones when they see the psychologists?
So CBT-I is a really robust treatment, and we think it's effective for a whole range of different comorbid disorders, different mental health conditions, other physical disorders, and also other sleep disorders. So CBT-I pretty well consistently improves insomnia across all comorbidities. And this is also the case for people who are and who are not using hypnotic medications at the same time as well. So if a patient is already using hypnotics, there's no need to withdraw them from hypnotics before starting CBT-I. They can absolutely start it while still using sleeping pills. What we do find is that patients that complete CBT-I, it's associated with a reduction in medication use, and about 20 to 40% of patients are able to cease sleeping pill use after completing CBT-I programs. So this is, like we said, because CBT-I targets those underlying causes of insomnia, and they find they have the confidence to improve their sleep and manage their sleep themselves, and that their sleep is improved and they no longer need the medications, which is, brilliant to see a program that can help patients reduce their dependence on these medicines.
Alexander, it's been really good to talk to you. I'm telling you, what is so exciting for me is that you have described both the importance of managing insomnia well. You've given us an idea of the massive magnitude of people suffering from this condition. And then we looked at how few resources are available because they're all so busy. And I'm just so excited to hear about this digital CBT-I that's being offered for most of the patients, not all. And I look forward to really learning more about your research as it goes along.
Thank you so much, David, for having me on and shining a spotlight on insomnia and the work that we've all collectively been doing here.
Do you want to say some key words to our listeners before we say goodbye?
I guess if any GPs or primary care clinicians are interested in learning more about any of the interventions or getting involved in the world of sleep medicine and sleep science, please reach out to me. The Australasian Sleep Association is a really diverse organisation. We've got about 1,000 members who are really passionate about all areas of sleep medicine and sleep health. So if I can't answer any questions myself, I'm very happy to direct your listeners to other clinicians or researchers that can.
It's been such a pleasure speaking with you, Alexander. Thank you so much.
Thanks again, David.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.